What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
What's up, everybody? Dr. Zach Baker here, and I've got with me Mr. Philadelphia himself, our sports resident, Christian Huckfeldt, who unfortunately is still recovering from this Super Bowl weekend. Christian, man, are you back to 100%, or are you still feeling the pain?
Oh man, it sounds like we have a little insult to injury here. I was a little hurting a little bit earlier in the week, and I thought Thursday morning kind of be back ready to go, enjoy the weekend. But man, it seems like it's just getting poured on.
It's at times I'm almost glad that my team does not make it far in playoffs, or some years not even make it to the playoffs, because then you don't have to deal with the sting of the Super Bowl defeat. But it was an awesome game, man. You couldn't have asked for a better game, high scoring. Both teams played really well, lots of big plays. Obviously, the result was not what you were looking for, but it was one of the more entertaining Super Bowls that I can remember watching. Today, we are going to cover one of the research articles that Christian picked for us, and we are actually just making our way back from Oakdale High School sports medicine class, where we did a guest lecture there. We went there earlier this fall. We went back here for their spring semester. When we went out there in the fall, I was the lead presenter for that, while Christian and Bami kind of got acclimated to the environment, got a feel for what the intention of those community outreach projects were. And then today, Christian and Bami actually led that this morning. So they took them through a really interactive lab on back and neck related injuries and some of the screening processes, evaluation methods, and associated interventions that we do in a PT environment. They did a phenomenal job with that today. But Christian, now with regards to this research article, can you talk to us a little bit about what the title was that you picked, how you came across the article, and really why you thought it would be a good one to deep dive into?
Yeah, absolutely. So the article is titled "The Catastrophization Effects of an MRI Report on the Patient and Surgeon and the Benefits of Clinical Reporting." And this is something I feel pretty passionate about. I feel like prior to coming into residency, I had a couple good experiences with both in physical therapy school and also through community groups like the Level Up Initiative and Calu Community, who really have kind of highlighted the importance of the words we use and the conversations that we have with patients and how really they can drastically change our outcomes in certain situations. And this is a study that really kind of highlighted my biases towards those, and so I thought it would be a good one to share with everybody else.
Yeah, and I'm glad that you went this route, because I think oftentimes we focus on the X's and O's of PT, and we think about the diagnostics, we think about the prognostics. This is the problem we found. This is the solution to that problem from, is it mobility? Is it strength? Is it just tissue healing that needs to take place? And I think oftentimes we forget the most oftentimes influential piece of that puzzle is how are we conveying that information to the patient? Or sometimes how are we conveying information from an interdisciplinary standpoint or to our other colleagues? And I think this article highlights the relevance and the importance of that. So, Christian, talk to us a little bit about what the makeup of the study was and how it was put together and what they were trying to figure out.
Yeah, absolutely. So this study actually has a couple different parts. I'll highlight two of them in particular. So the first part is the authors really tried to create a method of clinical reporting for MRI reports, meaning that typically radiologists use what's called routine reporting, where they use terms that we typically learn in science class, like degeneration and tear and stenosis and stuff like that, to describe whatever they found in the report itself. But we know those terms can kind of be scary for some individuals if they don't have the good scientific background and the scientific knowledge to know what that means. So the first part of the study, the authors tried to create a separate method of clinical reporting where they use certain characteristics or certain groups of words and phrases to continue to pass along the same idea behind the report without the exact same scary words. And then the second part is that they try to determine whether the use of clinical versus routine reporting causes various healthcare practitioners to change their opinion on the MRI report.
Cool. So essentially what they're doing is they're trying to get away of just some of the vernacular where they're using common anatomical terms and just physically describing what's on there. And like you alluded to, a lot of those times those descriptive words, tear, rupture, herniation, degeneration, stenosis, oftentimes they have a negative connotation associated with them. And I think part of that negative connotation may be just from previous experiences, or maybe they have family members, or they've read certain things about how these types of injuries typically play out. And I think the people who are creating the reports or communicating the information, oftentimes they are not communicating it with the intent of scaring somebody. They're simply just doing their job, and they're communicating, hey, this is what was found on there. This is, in a medical textbook, this is what it's described as, or this is the actual name for it. But some of those names have kind of taken on a life of their own over the course of the last several decades with regards to prognostics and outcomes and just other people's experiences with them. So I think it's pretty interesting to see, all right, if we take some of those words and we just tweak the verbiage a little bit, or maybe we rephrase how we're communicating it to them, does that have any effect on either what we are prescribing for them or how it's being perceived? And I know personally, this comes down to the art and the science of how you're interacting with the patient. And when you find something, there's a certain way that you can communicate what you found, and how you deliver it and how you present it is going to influence, one, does the patient believe you or not? Are you wishy-washy? Are you kind of beating around the bush? Are you not all that confident? Or can you confidently and directly tell them what's wrong with them? That interaction is going to play a role in, do they trust you or not? Do they believe you or not? Other things, such as the inflection of your voice, your tone, your demeanor, how you frame something up, is going to also influence, is this a positive or a negative thing that we're finding? If you're wincing and grimacing, saying, does this hurt? And you're kind of wincing and grimacing, yeah, you're probably going to convince somebody it hurts as you're poking on that spot. Versus just kind of benignly asking them, hey, what do you feel when I do this? There's different ways that you can almost intentionally or unintentionally, but subconsciously, evoke different responses from people. So, Christian, with this article, what did they actually end up finding when they swapped out some of these words?
Yeah, absolutely. So what they did is they really took these common terms, like I said, that you find in MRI reports: degeneration, herniation, tear, fissure, stenosis, radiculopathy, all of those. And they created and they used these other scales that exist in the medical terms to really kind of grade them 1 through 5 based on different scales that doctors and healthcare practitioners would already know. And then what they did is they took 20 individuals with an MRI confirmed or they had low back pain and they had a positive MRI findings, and they used the routine radiologist report, and then they also subbed out into this new type of reporting called clinical reporting, where they changed the verbiage, and they presented these each MRI to 40 different healthcare practitioners. So they did 10 spine surgeons, 10 orthopedic surgeons, 10 orthopedic residents, and 10 physiotherapists. And each healthcare practitioner opened every single one of the MRI reports, and they gave their opinion on the severity of the condition, 0 to 10, the choice of treatment, what they think would be best, whether it's something invasive like surgery or injection, or whether they should try conservative treatment. And then 3, rank from 0 to 10 the probability of requiring surgery. And I think the really neat component of it, too, is the research team tracked whether the healthcare practitioners' answers changed, whether they were using the routine or the clinical reporting. And so the results found that actually the clinical reporting, which is kind of changing the verbiage, significantly reduced the assessment of severity of disease, 0 to 10, for orthopedic surgeons, residents, and PTs. Clinical reporting also shifted to a decrease in magnitude of invasiveness of treatment, so either shifting from surgery to injection or injection to conservative therapy for both the orthopedic surgeons, the residents, and the PTs. And then lastly, the clinical reporting decreased the assessment for potential need for surgery for, once again, the orthopedic surgeons, the orthopedic residents, and PTs. The change in verbiage did not at all affect the spine surgeons' point of view and whether they thought the condition was severe, whether they thought they would need invasive or conservative treatment. But really for the other 3 characteristics, for the orthopedic surgeons, residents, and PTs, clinical reporting really shifted to a decrease in intensity and invasiveness of methodology.
That's interesting, and I don't want to say I'm surprised by it. I don't want to say that I expected it, but I think it does. It reiterates what we talked about earlier of how you convey a message is directly going to influence in a large majority of people how they take that message and the conclusions that they draw from it. And something that kind of hits home with me is I recently had a patient who had a very significant shoulder injury. Had a shoulder dislocation, and there was labral. I had the MRI report in front of me, and I was reading that prior to working with the patient. And I see multiple rotator cuff tears. I see labral tear. I see some bony changes. I see a lot of things on this MRI report that do not look good. And when you think about previous outcomes that I've had with people, or when you just start to frame up a picture of your head of who you think is going to do well with conservative versus who you think may lean more towards the invasive route, this probably would have been somebody that just based off their MRI report, never seeing them, I would have told them, go get surgery and I'll see you after surgery for your postoperative care. And this individual, when they came back, they were now able to raise their arm over their head. They could provide resistance in various positions, short lever, long lever, again, sagittal, frontal, transverse plane. You could provoke it if you wanted to. You could find instability if you searched for it. But what was showing up on their image, as we all know, does not always directly correlate to the level of function that they have. What my bigger take-home message was, when I looked at that report, I went into the evaluation almost babying that patient. And it took me a long time to get through the evaluation because I was underestimating what they were actually capable of based off what I was seeing on that report. So I don't want the tone of this to be, don't worry about what an MRI says. It doesn't mean anything. Everybody will eventually get better. Your symptoms aren't your report, because you can under-catastrophize something just as simply as you can over-catastrophize something. But I want people to remember that how we convey a message or what you're actually reading or being communicated to from an image standpoint, it's a piece of the puzzle. But you still need to do your due diligence. You still need to go through the motions of what you would normally do within a subjective and an objective portion of an eval. And you need to use your clinical judgment based on what you think is the most appropriate plan of care for that person, and try to filter out some of those biases before your interaction with the patient. Christian, I don't know what your thoughts are just on this article, your experiences now, being a PT, actually in the field, working independently and autonomously throughout the residency. What do you think?
Yeah, I think first and foremost, we have to understand that the education that we get in PT school, in medical school, in whatever type of advanced schooling that you're going to get is different than what people are getting in other facets of the world and other facets of business and economics and stuff like that. So if you have somebody coming in and they see their MRI report online and they see some of these words, I think it's important to just understand that they're probably going to Google right away and they're going to search it. They're probably going to find some things that aren't so great there. So just having an understanding of that may be the case when they come in, and they may have already either heard some other language from other healthcare practitioners or seen some things from online or family and friends, and they may have some notions, some preconceived notions as to the severity of their condition before they even walk in. And I think kind of evaluating that and seeing where their thoughts are and seeing how likely they are to kind of listen and those kind of things is really important, because if they have a really strong belief system that this is something, that this is really dangerous or really scary, if I come into my high horse right away and say, oh no, this is fine, this is probably an incidental finding, I don't know if that initial interaction is going to go as well, versus me saying, hey, so why do you think this? Or where did you hear this? Or hey, would you be willing to hear my opinion? Or would you be willing to hear kind of what I think about it? And then secondly, I think it's really important just to, with the patient in front of you, really just choose your terminology wisely. Saying things like, oh, you have a torn rotator cuff, or you have a tendinosis. Why can't we just say, you have an irritated rotator cuff, or it's sensitive, or it's achy, or it's a little aggravated? Why do we have to use some of those advanced terms? And I think some of it is reading the patient in front of you. So if sometimes you'll have a patient who says, hey, just tell me what you're seeing in there. So yeah, maybe using some terms are okay, but then again, if you have people who who don't have a good understanding or may seem a little bit more nervous about it, using other words, age-related changes versus degeneration, things like that may help to just shift their focus and shift their willingness to be more active and to start physical therapy.
And I think developing an alliance with the patient early on is important in regards to gaining their trust, building rapport, and you can be the best PT in the world with a patient who has a very high likelihood of success with conservative management. If they don't come back for any more PT appointments because they don't like you or they don't like their interactions with you, you're not going to get good outcomes if you're not even given the opportunity for that. So I think whenever you're discussing findings, whenever you're discussing injury histories or reports from imaging, you need to acknowledge things. And it doesn't mean that you don't be dismissive, you don't deny that they're there, but you can tactfully acknowledge them. Yes, there were some abnormalities that we found, or there were some differences that we found, at the patella tendon, the spot right below the kneecap. There is a little bit of irritation, there is some agitation there. I've often found giving them less information, but accurate information is important. If they want more information, they will ask. And the more questions they ask, the more you can kind of spoon feed them and the more that you can give them a little bit further in. But I think oftentimes we back our own selves in a hole because we speak too much during evaluations. We give them too much information to the point where we're almost provoking and producing more questions in their head that they want answers to that they didn't even know they needed answers to in the first place. So I think that's important to keep in mind of speak accurately, speak appropriately, but sometimes less is more when you are communicating to individuals. And another thing you had mentioned is we cannot be dismissive of just saying like, oh yeah, there was something, yeah, you had a herniated disc, but it doesn't really mean anything. You're one of like 50 other people in this room that have that. That may not be very well received for somebody who's had back pain for 17 years. You're the 5th different PT they've been to because the other 4 struggled to connect with them or struggled to have success with them. They've just taken off work. They've gotten childcare for the next 3 hours to get this to the appointment. They've rearranged their workday. And the first thing you say to them is, oh, it's not a big deal. And you think that you're doing them an actual positive by that because you're trying not to catastrophize. But we can go the other end of the spectrum where we become so dismissive and we downplay things with such a less sense of urgency than what may be necessary, where that can be off-putting to patients as well. And speaking candidly, until you operate at either end of those spectrums and you speak too much or speak too little or you overemphasize something or underemphasize something, unfortunately, you may not know what those limits are until you've done what I've done too many times and you put your foot in your mouth or you speak incorrectly on something and you have that interaction with the patient. And they kind of bring you back, humble you a little bit and bring you back to life in regards to, that wasn't the most well received. And I don't know if you've had the fun of that part of your career yet, Christian.
Oh yeah, absolutely. I mean, I think, like you said, there's both ends of the spectrum where you try not to use all these medical terms and try to overcomplicate it, and then sometimes you have a patient come in and they're like, hey, just give me the deal, tell me what's going on, and you're trying to do the opposite way because you don't want to freak them out, and then they leave and they're like, well, I still don't really completely understand what's going on. So I think it's a fine line, and at the end of the day, it's all about just trying to be better than you were yesterday and trying to be better than you were last week and last month and continue to improve those things. At the end of the day, as long as you can hold your head high that you're working on it and something that you are actively paying attention to, I think that's what matters.
Yeah, it's interesting. You work with some patients and you're having a conversation. You got to kind of figure out like, what are they looking for? Are they looking for the solution or are they looking for comfort? And in the end, they're going to need both of them. But which one you lead with may be a little bit more influential. And sometimes if you go down, the wrong road with them and you're trying to seek comfort for them and you never actually tell them what's wrong with them or what the game plan is, you just keep saying everything's going to be all right. Then they do leave and they go home and their spouse or their coworker or their friend says, hey, what's up with your shoulder? Oh, yeah, I don't know. Zach really never told me what was wrong. He just said that it would get better and this is what we had to do. And then they're walking around without a diagnosis or without a sense of what's actually happening in there, and they're almost underinformed. And at the same time, if you just give them the facts and you just give them the answer, but you do not give them the reassurance, you're going the other route where you potentially created doom and gloom with no solution, and you didn't bring them back down to reality with that. Christian, any other final thoughts on this, or any feelings on how it may influence you moving forward?
Yeah, I mean, I think this is one of those things that it's just like anything. You got to just try to be better over time. It's nothing that you're going to be amazing at the first time you do it, and you're going to have times where you go out there and you try to explain something and it doesn't come off the way you want it to. And that's just a good time to go home. One thing I heard from, honestly, I'm not even sure who I heard it from, is that every day on the ride home, you replay kind of every patient interaction you had for like 2 to 3 minutes, and then you move on. And it's just a good way of just quickly debriefing about what went well, what didn't go well, what you could have communicated better, and then you move on, and then you go to the next one. And then if you kind of get into that routine every day where you're just doing a quick debrief of how the interaction went, it gives you an idea of where you need to improve on next time, and then you do it.
But we're fortunate enough where at the location you and I both work out of, we have 10 and soon to be 11 PTs that operate out of there. We have everyone ranging from first year out of PT school to 12 years of experience and everywhere in between. We have people that have come from different PT schools. We have come from people who have worked with R2P the entirety of their career versus working in multiple other settings. So one thing that I like to do is just kind of be a fly on the wall sometimes and listen to how the other people in the room are interacting with patients. And I often find that a lot of the verbiage and a lot of the strategies that I use are ones that I've found my coworkers having a lot of success with. So I think if you are a new grad or you're early in your career, make that a habit. Have conversations with people on staff or just see what their delivery style is, the type of verbiage that they use. If you have been practicing for a while, keep in mind that you may have fallen into a certain rhythm or a certain pattern that sometimes you need to change it up and you need to get another fresh perspective. So part of the reason why I like having students, one, they often ask really good questions, but you also get students from a variety of different backgrounds with a variety of different experiences, and it ends up being a learning experience for all. So Christian, I appreciate you taking the time and the effort to go through this one. This was a really good article. You and Bami did a great job of picking articles, I think, hit on a wide variety of the low back pain spectrum, and I know that I will be able to use this in my clinical practice moving forward. So thank you, Christian.
Thanks so much, Jack.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.